Thanks very much, Dirk and PK, for including me. And these are my as you've heard, and some very eloquently, that the bare metal stents, about various DES rather, and DEBs. Bare metal stents have improved outcomes over PTA and the SFA, but longer lesions have been a predictor of lower patency at 12 months. And drug-coated balloons have demonstrated promising 1- and 2-year results in randomized trials, and certainly with the IMPACT Admiral DCB showing sustained treatment benefit out to 4 years. DCB evidence has been greatly expanded in real-world registries, as you've just heard, again, very effective or eloquently talked about. But effectiveness in complex lesions associated with increased reliance on bailout stent use. And despite the efficacies of DCBs, will this technology replace the benefits of scaffolding that stents provide? So what are the clinical considerations? You know, the assessment of clinical presentation outcome goals does affect revascularization strategy, and this is one of the things that is the practical aspect of what we do in the real world. Does the patient have lifestyle-limiting claudication or chronic critical limb ischemia with tissue loss? Is revascularization warranted to allow a limited amputation to be successful? What are the anatomical morphologies? And you've again seen in the previous talks that there's quite a difference in what lesions were treated and which ones were excluded. What's the location? What's the length? Is there diffuse calcification? And has there been previous intervention? So this is just a case that I did fairly recently. You can see this is a patient with an occluded bypass graft that, and you can see this is a very complex patient with diffuse calcification that clearly this is not one that perhaps may have been included in Dr. Zeller's comments on the last trial that he presented. And again, not all lesions are created equal. So what are the failure modes? Elastic recoil, dissection with poor initial luminal gain have traditionally been the Achilles heel of percutaneous balloon angioplasty. Long lesions and dense calcification have also been associated with both short-term and longer-term outcome failures. So DCBs have recently demonstrated reduced late lumen loss compared to plain old balloon angioplasty, but many of the studies excluded these long, complex, or highly calcified infrainguinal lesions. So now stents provide scaffolding to overcome dissection and recoil, allowing for improved luminal results, particularly in total occlusions. The early stent designs, unfortunately, were not very adaptable to the anatomical and vasomotion found in the SFA distribution. Short stents requiring multiple overlaps and other design failures led to fracture and restenosis. However, improved metallurgy, longer lengths, and drug coatings have resulted in improved outcomes and decreased target lesion revascularization. And again, just a variety of different patency trials with the SFA stents, and you can see really 12-month primary patencies really were very good in many of these trials. This is from John Matsumura from the durability trial, again with Kaplan-Meier showing just under 80% patency at 12 months. This is obviously a bit redundant because you've already seen many of these Zilver slides, but again, this is with the drug demonstrating really excellent patency even out to 5 years. And then freedom from target lesion revascularization, which is really probably the most important criteria that we use in judging the efficacy of these various strategies. And again, this is from Dr. Zeller's work demonstrating clearly that the in-stent restenosis using paclitaxel-eluting stents and really very excellent patency. Now, these are advances in technology, improved stent designs, longer lengths, improved metallurgy, and now drug coatings have improved clinical efficacy and reduced TLR. The cost of reintervention is also not insignificant. Therapy that's proven to avoid TLR accrues major economic value over time and imparts value. I think what must new technologies do, and this is really the challenges I think that I personally think face drug-eluting balloons. You have to optimize outcomes, improve long-term vessel patency. You have to allow optimal treatment for the more difficult lesion subsets, particularly those with long lesions and those with diffuse calcification. There's cost-effective or of value. We need longer balloon lengths and we need decreased cost. You know, if you look at the cost of many of these self-expanding stents, they're relatively inexpensive in comparison to the drug-eluting balloons. So improved strategies for combining modalities such as atherectomy and stents to achieve optimal and durable outcomes. And obviously, many of the people here in the speakers have been very involved in a number of these studies that are ongoing. There is, I think, the cost challenge I wouldn't underemphasize, despite the cost analysis by Peach and colleagues demonstrating the economic benefit of drug-eluting balloons and drug-eluting stents because of reduced TLR. We continue to have economic barriers, both from the payers and industry, that make cost a significant issue. And just in the last 2 slides to illustrate the comparative issues of cost and value, there's a meaning to the old expression, penny wise, pound foolish. This is the easy education that you can get. You can earn an affordable correspondence degree, no exams, no studies, $199 in 15 days. Or you can go to Stanford and spend 4 years and $120,000, but it does require study exams and a commitment. Thank you for your attention.